There are a number of considerations when planning iliac artery intervention, including vascular access site. Options include a unilateral common femoral approach, an upper extremity approach, and a bilateral common femoral approach. When considering unilateral common femoral approaches, there are ipsilateral and contralateral options. Ipsilateral access offers better catheter and wire support, while contralateral access allows contrast injections that define the distal target vessel during wire crossing. Brachial artery access is associated with a higher risk of access site complications when compared with radial artery access or common femoral access, and the distance from the iliac arteries weakens catheter support. However, this approach may be helpful for defining iliac anatomy and target lesions when contralateral femoral access is not available. Radial access carries a low risk of access site complications, and as with brachial artery access, is helpful for defining anatomy when contralateral femoral access is not available. However, the distance from target vessel eliminates many standard catheter and stent options. With respect to bilateral common femoral access, this approach allows simultaneous crossing from above and below the occlusion. Real-time angiographic imaging of the proximal and distal target vessels also allows more directed wire manipulations. There are a number of anticoagulation options available, including unfractionated heparin and bivalrutin. However, these have not yet been compared in a published randomized trial. With respect to unfractionated heparin, this agent can be used with lower ACTs during CTO crossing and higher thereafter. Heparin is reversible in the case of perforation, but requires monitoring throughout the procedure. In contrast, bivalrutin provides reliable anticoagulation without the need to monitor therapeutic effect, but it is not reversible, and despite its short half-life, may be less safe in CTO lesions. Again, these agents have not yet been compared in published randomized studies. It should be noted that when sized correctly, chronic outward force aids vessel apposition. However, excessive chronic outward force can lead to injury and neointimal hyperplasia. When choosing the ideal stent, there are several available options. Balloon expandable stents have high radial strength and predictable deployment. However, there is variability amongst products in conformability. Self-expanding stents are crush resistant, highly conformable, and have moderate radial strength. However, there is variability amongst products in ability to position. Finally, covered stents can provide coverage during rupture and prevent tissue ingrowth. There is no stent which exhibits all the ideal properties required, and therefore interventionalists will need to keep a range of stents available if all lesions are to be addressed. Three cases will be discussed during today's podcast. These include a CTO of the common iliac arteries, occlusions at the external iliac artery bifurcation, and multiple external iliac artery lesions in the setting of common femoral artery disease. Case 1 is a 38-year-old man with a history of dyslipidemia, hypertension, type 2 diabetes, coronary artery disease status post 2 prior stents, and current smoking. He presents with left calf fatigue and pain when walking that resolves with rest. He failed 1 year of supervised exercise therapy. His current medical regimen includes aspirin, lisinopril, atorvastatin, metformin, and xylostazol 100 milligrams twice daily. On physical examination, right femoral pulse and right pedal pulses are palpable. His left femoral pulse is palpable but diminished, and his left pedal pulses are only dopplerable and biphasic. Both feet are warm, and there were no stigmata of critical limb ischemia. His left ABI at rest was 0.62, and after exercise 0.29. The drop in ABI after exercise is consistent with a vascular cause of his leg pain, making other causes like radiculopathy or degenerative joint disease less likely. He subsequently underwent CTA, which demonstrated occlusion of the left common iliac artery, and an invasive angiogram, which confirmed the CTO in the left common iliac artery and noted mild calcification. When faced with a patient like this, one might consider surgery, such as a fem-fem bypass or an endovascular approach. Favoring an endovascular approach are the fact that it is less invasive, associated with a lower risk of morbidity and mortality, has a shorter length of stay, shorter recovery, and surgical options may be preserved. However, there is some debate about the long-term durability of these two options when compared with one another. Again, there are a number of considerations with respect to vascular access site and anticoagulation. Favoring an ipsilateral retrograde approach are the good support and the fact that one can possibly cross and treat from a single access point. However, there may be a need to gain reentry directly into the aorta. The contralateral up and over approach allows reentry into the external iliac artery and allows protection of the unaffected common iliac artery from jailing. However, there is less support and it may be difficult to treat the iliac in question in the setting of severe aortoiliac angulation. A radial or brachial approach provides somewhat less support but allows entry directly into the external iliac artery. There are sometimes difficulties with arm and operator positioning when using these approaches. With respect to anticoagulation, unfractionated heparin may be preferable. One can titrate the ACT during CTO crossing so that it is lower at this stage, but higher thereafter. Again, unfractionated heparin can be reversed in the case of perforation. There are a number of stent features that should be taken into consideration. These include radial strength, conformability, foreshortening, deployment accuracy, chronic outward force, crush resistance, expansion, stent material, and surface characteristics. Imagine this were a heavily calcified, totally occluded, near-flush occlusion of the common iliac artery. Aside from concerns regarding crossing techniques, one must also take into account stent selection. The ideal stent would have precise placement with good radial strength and would be fracture resistant. Had a totally occluded common iliac artery. The interventionalist utilized a left radial artery access approach and placed a balloon expandable stent for better precision and radial strength in the common iliac artery, followed by a self-expanding stent overlapping into the external iliac artery. The decision to use two stents was based on limitations of currently available balloon expandable stents, with the longest on the market being 59 millimeters. Following the procedure, many operators would prescribe dual antiplatelet therapy using aspirin 81 milligrams and clopidogrel 75 milligrams for at least 1 month. It should be noted that there is limited evidence supporting this approach. and this is derived largely from the coronary artery bare metal stent literature. Options for routine clinical surveillance include an annual exercise ABI, assessment clinically, or exercise and/or resting duplex or Doppler. Case 2 is a 65-year-old former smoker with dyslipidemia and coronary disease status post prior PCI. He presented with right calf and buttock claudication after walking 200 yards. He had no improvement after 3 months of silostazole therapy. He, as a consequence, stopped exercising and playing golf. His current medications included aspirin, lisinopril, atorvastatin, and atenolol. While there are other potential causes of exertional leg discomfort, hemodynamically significant PAD is high on the differential. Buttock discomfort suggests involvement of the internal iliac artery either directly or indirectly by a stenosis in the common iliac. On physical examination, his right femoral pulse and right pedal pulses were not palpable. Left femoral pulses were palpable but diminished. Both feet were warm, and elevation pallor was present in the right foot. His resting ankle brachial indices in the office were 0.66 on the right and 0.8 on the left. In contrast to the first case, the predominant disease is on the right. The development of pallor upon elevation is an indication of severe PAD, particularly if it occurs in less than 30 seconds after elevation. Resonance angiogram, shown here, confirms the presence of severe right and moderate left iliac artery disease. There is a severe stenosis in the distal right common iliac artery at the origin of the right internal iliac, and the right external iliac artery is occluded. The right common femoral artery reconstitutes above the inguinal ligament. On the left, the iliac system is tortuous, the left common iliac artery is stenosed, and there is an occluded left internal iliac artery. There are a number of potential treatment options here, including surgical bypass, endovascular intervention, or a hybrid procedure. The decision whether to proceed with endovascular or surgical revascularization depends on several factors, including complexity of disease and anticipated durability of the procedure, patient characteristics and medical comorbidities, which may influence surgical outcomes, and operator experience. There are no contemporary randomized trials evaluating the safety and durability of endovascular and surgical revascularization for aortoiliac disease. Some of the older data available are summarized in the following slides. The often quoted Task 2 recommendations may serve as a general guide in such decision-making. However, the Task 2 lesion classification may or may not apply to every clinical scenario, as comorbidities and operator experience weigh heavily in deciding whether surgical or endovascular therapy is selected. Surgical options would have included an aortobifemoral bypass graft, which is a significant operation. A less morbid hybrid approach could have been chosen in a high-risk patient. This might have included stenting of the left common iliac artery and a fem-fem bypass from the left to right common femoral arteries. The durability of this type of surgical revascularization, however, is lower. In this particular case, because of the patient's preference and operator's experience, an endovascular approach was chosen. Aortobifem bypass remains a very durable surgical option. Its primary disadvantage is the associated mortality and morbidity. With improved durability of endovascular iliac therapies, aortobifem bypass is reserved for most complex aortoiliac disease not amenable to percutaneous intervention. Iliac artery stent patency across 5 studies. In these studies, 1-year patency was greater than 93%, 2-year patency over 90% as well, 4-year patency approaching 80%, and 8-year patency in one study above 70%. Two older randomized studies compared surgery with angioplasty for iliac artery disease. In the VA randomized study and the Swedish study shown here, there was a 15% initial failure rate with a balloon angioplasty, high by most modern standards. Contemporary results with stenting are more durable even in complex lesion subsets. There are a number of considerations regarding vascular access and anticoagulation for this patient. With respect to access, ipsilateral retrograde is one option that would provide good support. However, the short distance between the common femoral sheath entry site and CTO distal cap might risk loss of access during the procedure and could make stenting the distal external iliac artery difficult. The contralateral up and over approach is another option. This would enable deployment of a stent in the distal external iliac artery. However, the tortuosity on the contralateral iliac would be difficult to navigate and would provide less support than an ipsilateral approach. Finally, an upper extremity approach using either a radial or brachial access would provide reasonable support. There would be lower bleeding with the radial access, but higher with the brachial access when compared with a common femoral artery approach. An upper extremity approach would avoid contralateral iliac tortuosity. This approach is sometimes limited by arm and operator positioning and by equipment reach. With respect to anticoagulation, similar options are available as with the first case, and heparin may be a better choice given the need to cross a CTO and the possibility of need for reversal in the setting of perforation.